The title of this talk is Physiology of the Lower Motor Neuron and Spinal Reflexes. The talk will be conducted using conversational and question and answer formats. These are the class objectives. You do not need to read them. We will use them to chart our talk. The first question is, the desire to move a limb is generated in the precentral gyrus. A true, B false. This frame shows the lateral surface of the left hemisphere and the mesial surface of the right hemisphere. As you can see, the magenta color region of the brain consists of the motor and motor-related areas, the executive areas. The aqua, the sensory or perception area. The sensory area strongly influences the motor area. The motor area also influences the sensory areas, though probably to a lesser extent, thus forming massive neuronal circuitry between them. A neural circuit is a population of neurons interconnected by synapses to carry out a specific function when activated. Neuronal circuitry allows us to interpret our environment and react to it. Environment is registered and interpreted by the sensory area, and the motor area affects environment. The motor area has a hierarchical organization and can be divided in three hierarchical orders, as you can see in this frame. The primary cortex is represented in the lateral surface. It is represented in front of the central sulcus and in the mesial surface at the anterior gyrus of the paracentral lobule. The primary motor cortex is organized as you can see in this frame. Legs are mesial, the face in the lower lateral surface, and the pharynx little below. This is a photograph of Penfield, the man who mapped the cerebral cortex. This is the actual drawing he published in 1954. He called the precentral motor cortex the Rolandic motor cortex. The second order hierarchical region is the unimodal association cortex. This area is where the scripts for specific high-order movements are kept. This area is referred to as the premotor cortex. The premotor cortex is found in the lateral hemisphere. In the lateral hemisphere, it is located in front of the primary cortex, and it is divided into 4 regions. I will now proceed to indicate the different regions. The first region of the premotor cortex is the premotor area. This area is present in both hemispheres. It has the script for body movements in general. The second region in the premotor cortex that I will mention has a different function in each hemisphere. In the dominant hemisphere, the region just indicated is called Broca's area, and as you know, is fundamental for language. In the non-dominant hemisphere, a similar region at about a relatively similar position deals with speech intonation. The third region of the premotor cortex is the Exner area. In most people, this area is in the dominant hemisphere. It has the script for writing. The fourth area is the area of saccadic eye movements. This area is present in both hemispheres. The premotor cortex is also represented in the mesial surface of the brain. It is located in front of the primary motor cortex. The unimodal association cortex at this location is called the supplementary motor area. This area was also mapped by Penfield and Jasper, to which they refer to by the name still in vogue, the supplementary motor area, or SMA. The third order hierarchical region is the multimodal association cortex. It is called so because it integrates not only motor signals but also signals from other modalities such as touch, vision, hearing, and most authors believe it also harbors the will. This area goes by the name of prefrontal area. In the lateral surface of the hemisphere, it occupies the frontal pole, as you can see here, indicated by the green arrow. In the mesial surface of the brain, as you can see in this new frame, it occupies most of the frontal pole. The anterior cingulate gyrus is sometimes not considered part of the multimodal association cortex by some authors, but it is considered so by others. So, at this junction, and with high degree of uncertainty, we can say that the will to move appears to initiate from the prefrontal area. From here, the signals go to the premotor cortex, that after integrating motor information from the basal ganglia and the cerebellum, sends the signal to the primary motor cortex. So the answer to this question is B. Next question. Sherrington is credited with the conceptualization of upper and lower motor neurons. A true, B false. This frame shows a photograph from the 5th edition of Sherrington's book, Integrative Action of the Nervous System. This book was published in 1947. Sherrington, in 1906, while lecturing in the United States, had introduced the concept of upper and lower motor neurons. But it was not till the publication of this book that the idea became one of the cornerstones of neurology. This is one of the diagrams he used in the original lectures to explain the concept of upper and lower motor neurons. I will first point to you some structures for orientation. These are the ears, upper extremity, lower extremity, and the main point of the diagram, the lower motor neuron and its connections. He idealized that a muscle fiber was connected to a nerve fiber that came from a neuron, in this case from a spinal cord neuron. And he called this arrangement the final pathway. And then he went on to say that this neuron was influenced by information from the same muscle it innervated, from other neurons at other segments of the spinal cord and brainstem, and from one neuron in the brain. He viewed all these interconnection as reflexes, but went on to add that the concept he had been so broadly praised for was a convenient, if not a probable fiction. Regardless of his doubt, the concept catch on, and today we talk about the lower motor neuron, here indicated in this cartoon and here in his drawing, and we also talk about the upper motor neuron, here represented in the cartoon and here in his model. So the answer to this question is A. Next question. The neuron innervating the intrafusal fibers is called dash motor neuron. A alpha, B beta, C gamma, D delta. We will start by drawing the contour of the central nervous system to further analyze the concept of lower and upper motor neurons. So this is the brain, the lateral ventricles, the brainstem, cerebellum, and the spine. Next, I will introduce the upper motor neuron. So we will go back to the sketch to introduce the upper motor neuron, the body of the neuron in the cortex, in the precentral gyrus and the anterior gyrus of the paracentral lobuli. Now I am introducing the axon traveling through the centrum semivalley towards the internal capsule, then through the brainstem, all the way to the spine. Next, I will introduce the lower motor neuron complex. So we go back to the sketch and introduce the lower motor neuron complex, here conveniently represented as the sole source of innervation of a muscle. The lower motor neuron complex includes the lower motor neuron, alpha, which are bigger and go towards larger motor fibers, or beta, which are smaller and go to smaller muscle fibers. I now indicating the axon, the neuromuscular junction, the muscle, and the tendon. This representation was the first model used to explain movement based on the upper and lower motor neuron concept. But though useful, it was not capable to explain many conditions seen in everyday clinical practice. So changes were made. Instead of talking about upper motor neuron, we talk about upper motor neuron system. And instead of talking about lower motor neuron complex, we talk about lower motor neuron system. I will start by further describing the upper motor neuron system. The first component I will introduce is a neuron in the cerebellum with its axon crossing to the other side, contacting a second neuron in the red nucleus. The second neuron sends an axon that projects to the thalamus, specifically to the ventrolateral nucleus of the thalamus, where it connects with a third neuron. From the thalamic neuron, axons go to the cerebral motor cortex. We will now address the lower motor neuron system. This system includes the intrafusal fibers or muscle spindle fibers, the sensory nerve, the sensory neuronal body in the dorsal root ganglia, and the central axon of this neuron that makes contact with the lower motor neuron as indicated in this frame. In addition, this model also has a motor neuron going to the intrafusal fiber in the muscle spindle. This motor neuron is called the gamma motor neuron. All the constituents of this model for the spine also are represented in the brainstem for striated brainstem muscles. So the answer to this question is C. Next question. The nucleus ambiguous is shared by cranial nerve 9, 10, and 11. A true, B false. This figure shows isolated clusters of lower motor neurons forming distinct nuclei. This is the nucleus for the third nerve. This is the nucleus for the fourth cranial nerve. And this is the nucleus for the fifth, and so forth. The nucleus ambiguous is shared by the glossopharyngeal nerve, from where the stylopharyngeus muscle is innervated, the vagus nerve, and the spinal accessory nerve. So the answer to this question is A. Next question. In the spinal cord, the motor neurons for different striated muscles are in the anterior horns. A true, B false. Muscles in the body are innervated by motor neurons in the anterior horn of the gray matter of the spine. Nerves for the brachyradialis muscle are clustered in the anterior horn, extending from C5 to C7. Motor neurons for the biceps are between C5 to C6. The motor neurons for these muscles share spinal segments levels as shown in this figure. You can see that the motor neurons of both muscles intermingle in the anterior horn of the cervical segments 5 and 6. So the answer to this question is A, true. Next question. A motor unit is made up of a lower motor neuron and the skeletal muscle fibers it innervates. A, true, B, false. This drawing depicts a motor unit. The motor unit consists of the lower motor neuron that can be in the spine as shown here, but can also be in the brainstem. Its axon collateral, as you can see here, and here, and all the muscle fiber it innervates. Based on the speed of conduction, motor neurons can be classified as alpha, those conducting the fastest, and beta, those with lower conduction velocity, and also smaller bodies. Lower motor neurons can also be classified according to the muscle fiber type they innervate. Type 1 motor neurons are smaller and innervate small extrafossil fibers. Type 2A motor neurons are medium size, and type 2B motor neurons are the largest. As a matter of fact, innervation is what dictates muscle type fiber, as we will see in the next few frames. Hence, if a type 1 muscle fiber is deprived of innervation by a type 1 motor neuron and is reinnervated by a type 2B motor neuron, the newly reinnervated muscle fiber becomes a type 2B muscle fiber. So the answer to this question is A. Next question. The physiologic unit of force generation in muscle is the muscle fiber. A, true, B, false. This is the same representation of the upper motor neuron and lower motor neuron I showed you before. In this frame, I have removed 4 nerve terminals with their respective muscle fibers and only left 2 nerve terminals with their corresponding muscle fibers. Now I have enclosed the distal structures and enlarged them so we can go through their different components. The arrow here points to myelinated segment of an axon, representing the end of the collateral axon. Now I am pointing to the myelin, represented by the gray cylinders. Now I am pointing to the Schwann cell, and now to the nucleus of the Schwann cell covering the myelin. Notice that the terminal axon, although not covered by myelin, are covered by Schwann cells. This part of the axon is called the telodendria. Here, the arrows are pointing to the nuclei of the Schwann cells. Now the arrow points to the most distal portion of one of the nerve terminal. As you can see, if you have a good imagination, the nerve terminal at this point is spread as a flower bouquet. This romantic configuration of the nerve terminal is not present in all muscle fibers. Here I am providing a view of the distalmost region of the nerve terminal, consisting of one presynaptic bulb in the bouquet, which I have enlarged in this frame. We normally refer to this region as the synapse, but in a strict neuroscientific terminology, The term synapse is reserved to the specified contact zone between two neurons, where the two neurons communicate. And the term neuroeffector junction is used for the contact zone between a neuron and a non-neuronal effector. So properly speaking, we should call this structure a neuroeffector junction, yet the use of presynaptic region for the neural element, synaptic region for the cleft, and postsynaptic region for the muscle element is so prevalent in the literature that we will continue to call this junction a synapse in order to sustain the regional labeling. It is also important to clarify that the reason we can use a single synapse bulb to explain the functioning of a flower bouquet with its multiple synaptic bulbs is that the flower bouquet works as a unit. What happens in one synaptic bulb happens in all synaptic bulbs in a given bouquet. It is also important to stress that what happens in one flower bouquet will happen in all flowers bouquet belonging to one motor neuron. Thus, we cannot physiologically activate just one muscle fiber, nor a few muscle fibers innervated by one motor neuron. The smaller number of muscle fibers that can be physiologically activated are all those belonging to one motor neuron. Having made this observation, I will go on labeling the different areas of the synapse. So, in the neuromuscular junction, we find a presynaptic region, a synaptic cleft or region, and the postsynaptic region. The postsynaptic region is a specialized muscle segment present in each muscle fiber called the muscle fiber end plate. The muscle fiber end plate is continuous with the muscle fiber. The muscle fiber extends from one end of the muscle to the other. Each muscle fiber is connected to the tendon at each end of a muscle. So the answer to this question is B. Next question. The structure indicated by the arrow is a flower bouquet terminal. A true, B false. In this frame, I have enclosed an area of the nerve terminal that corresponds to the histological picture I have just shown in this frame. The segment of the terminal axon indicated by the arrow in the cartoon corresponds to the structure indicated by the arrow in the histological preparation. The area encircled in the cartoon corresponds to the area encircled in the histological preparation. The structure indicated by the arrow covered by Schwann cell is the end plate. The structure by the side in continuity with the end plate is the muscle fiber. The muscle fiber also has many components that are discussed at other courses. So the answer to this question is true. Next question, type dash, muscle fiber looks red, are used for slow and sustained contractions, are small, aerobic, and located deep in the muscle. A, 1, B, 2A, C, 2B, D, 3. Microscopically, we can divide muscle fibers in different types that have rather specific metabolic and physiologic characteristics. Type 1 are innervated by relatively small motor neurons. Type 1 motor fibers are small too, they are red and contract slowly. They have high myoglobin and oxygen content, thus used for aerobic activity. The mitochondrial density is high, thus have a high oxidative capacity, as previously mentioned. Their main source of energy is triglyceride. Glycolytic capacity is low. The capillary density is high in order to meet the oxygen demands of the fiber. They have high endurance, thus resistance to fatigue is very high, but generate little force. Type 2A muscle fibers are innervated by relatively middle-sized motor neurons. Type 2A muscle fibers are not as red as type 1 motor fibers, and contraction is moderately faster. The mitochondria density is rather high, thus have a high oxygen capacity, the main source of energy being creatine phosphate and glycogen. The capillary density is intermediate. Endurance is fairly high. The power of these muscle fibers is higher than type 1 motor fibers. Type 2A fibers are used for long-term anaerobic activity. Type 2B muscle fibers are innervated by the largest motor neurons. Type 2B motor fibers are large and contraction time is very fast. Mitochondria density is low, hence oxidative capacity is low, glycogen capacity high, and major storage fuel is creatine phosphate and glycogen. Capillary density is low. Endurance that is resistant to fatigue is also low, but the force produced by them is very high. Most human muscle have a mixture of type 1 and 2 fibers in a proportion of 4 type 1 to 6 type 2. The different type of fibers are not distributed equally in the muscle. Type 1 fibers predominate in the center, type 2A more peripherally distributed, and type 2B even more peripheral. Best way to memorize fiber types: think of the distribution of the fibers in the chicken. Red in the legs, white in the breast. Think on what they are used for. And that mitochondria are very prominent in red muscles. Deduce all else from there. So the answer to this question is A. Next question. One motor neuron stimulating 100 muscle fibers is an example of A. Temporal summation, B. Spatial summation, C. Convergence, D. Divergence. This question includes 4 important and simple definitions. The first one is divergence. Divergence implies that one neuron activation leads to activation of more than one neuron or an organ. The best example is found in the peripheral nervous system. One motor neuron activation leads to contraction of multiple muscle fibers. The second is convergence. Convergence implies that more than one neuron activation converge in a single neuron. The third term is a spatial summation. In this frame, you can see action potentials for a single neuron reaching a larger neuron but not producing an action potential. In this frame, you can see the action potentials of 2 neurons reaching the larger neuron at different sites but still no action potential. In this new frame, you can see the action potentials of 3 neurons reaching the large neuron and producing an action potential. This represents an example of spatial summation, the stimulation of 3 different sites, that is, an increased area of stimulation in the larger neuron at the same time produced an action potential. The fourth term is temporal summation. During temporal summation, one neuron discharge firing increased in order to trigger an action potential. Here you see one neuron discharging but no action potential. Now the same neuron discharges for a longer period of time and still no action potential in the larger neuron. But with increased discharges, as you can see in this frame, corresponding with increased duration, the larger neuron will have an action potential. This is an example of temporal summation. In temporal summation, the number of discharges increases, hence discharging time duration increases, but the area being stimulated does not change. So the answer to this question is D. Next question. A dash neuronal circuit sends impulse back to a previously involved neuron within the circuit. A. Parallel after discharge, B. Reverberating. This is a representation of a reverberating system. A reverberating system sends impulses back to a previously involved neuron within the circuit. In a parallel after discharge circuit, a neuron inputs to several chains of neurons, in this case 2, that converge onto one output neuron. Each synapse in the circuit delays the signal by about 0.5 milliseconds. So the more synapses in a circuit, the longer the delay from the input neuron to the output neuron. This circuit is often used in the brain for problem solving. So the answer to this question is B. Next question. The knee-jerk reflex is a polysynaptic reflex. A true, B false. For the purpose of answering this question, we will define reflex and then proceed to talk about 4 reflexes. Reflex can be defined as an input-output neural circuit required for environmental adaptation. The 4 reflexes we will address while answering these questions are the stretch reflex, the inverse stretch reflex, the withdrawal reflex, and the withdrawal cross extensor reflex. We will first talk about the stretch reflex. We will use this figure to illustrate a classic stretch reflex, the knee-jerk reflex. This is the quadriceps. This is a muscle spindle. The sensory fiber traveling in the femoral nerve from the muscle spindle enter the spine and go directly to the anterior horn. At the anterior horn, they synapse with lower motor neuron supplying the quadriceps fibers. A tap to the patella tendon is followed with a minimal delay by leg extension. This is called a monosynaptic reflex because it only makes use of one synapse in the spinal cord. This is a very fast reflex because there is only one synapse in the spine. And since it involves the patella tendon, it is called the patella reflex. I will explain this reflex in more details in the next few frames. Here I am representing a monosynaptic reflex. This reflex is called a stretch reflex because it is triggered by stretching the muscle. When extrafusal and intrafusal muscle fibers, which are in parallel to each other, are stretched, the sensory component of the muscle spindle senses the change in length and, we could say, wants to return to the previous length. The extramuscle fiber obeys and contracts, shortening the muscle and returning the intrafusal fiber to its original length. Now we will talk about the inverse stretch reflex. We will use a similar model as we did to explain the stretch reflex. The receptor in this reflex is the Golgi tendon organ, often called by its initial GTO. The GTO has a peculiar configuration because of its internal machinery. As you can see in this frame, the internal machinery of the GTO is made of sensor or modified nerve components, here illustrated in green, intertwined perpendicularly between the strands of collagen. Hence, when the GTO is stretched, as illustrated here, the holes between the strands of collagen narrows, compressing the nerve fibers, which send a signal that travels towards the dorsal root ganglia, enters the dorsal horn, and makes contact with an inhibitory interneuron, whose axon makes contact with the motor neuron innervating the muscle that originally the sensor signal came from. The result is that neuron will be hyperpolarized. That is, the motor neurons become hyperpolarized, thus preventing it from further discharging. In the absence of further motor neuron discharge, the muscle relaxes. Hence, the previously narrow conduits through which the nerve were traveling, as indicated here, relaxes, making the conduit through which the nerve fibers travel wider, as indicated here, thus relieving the compression of the nerve fibers. The inverse stress reflex is thus a polysynaptic reflex because it involves not one, but two interspinal synapses, hence slower than the monosynaptic reflex, which only has one interspinal synapse. In the inverse stage reflex, the receptors are in series, so it is the shortening of the muscle due to muscle contraction that activates the receptors. And the result is that neuronal security prevents the involved motor neuron from firing, thus returning the muscle to its original pre-contraction size. Now we will talk about the withdrawal reflex. The withdrawal reflex consists of removing the limb from a painful stimulus. In this example, the perception of heat transmitted to the dorsal root ganglion cell, whose proximal axon synapses with an excitatory interneuron in the dorsal horn. This excitatory interneuron then contacts an anterior horn motor neuron. The anterior horn motor neuron activation triggers the contraction of the body part in contact with the noxious stimulus, as shown here. This is a polysynaptic reflex because it has not one but two interspinal synapses. Remember that, strictly speaking, the neuromuscular junction is not a synapse but a neuroeffector junction. Also remember that synaptic transmission, that is, from the time it takes for current in the presynaptic neuron to be transmitted to the postsynaptic neuron, is approximately from 0.3 to 1 millisecond, and in the neuromuscular junction is about the same time. Next, we will talk about the withdrawal cross-extensor reflex. The withdrawal cross-extensor reflex is more complicated than the reflexes that we have previously reviewed. A noxious stimulus applied to the plantar surface of the foot triggers flexion of the thigh, flexion of the foreleg, and dorsal flexion of the foot affected by the noxious stimulus. At the same time, all the muscles in the opposite leg responsible for stiffening the leg become activated. The tibialis anterior, responsible for dorsiflexing the foot, is inhibited. The machinery for this reflex, as well as for walking, is in the spinal cord. As I have indicated here, the arriving signal to the spinal cord triggered by the noxious stimulus diverts and interacts with excitatory interneurons in the ipsilateral dorsal horn. The axon from these neurons make ipsilateral contact with inhibitory neurons that hyperpolarize those extensor promoting neurons, and with ipsilateral excitatory interneurons whose activation promote leg withdrawal. Similarly, ipsilateral excitatory interneurons in the dorsal horn will send their axons to the contralateral anterior horn. There, they will make contact with excitatory interneurons, which will themselves contact lower motor neurons, whose activation will lead to a stiffening of the leg, and with inhibition of neurons, which will hyperpolarize lower motor neurons that do not promote leg stiffness. So the answer to this question is B. Next question. Rentschau cells inhibit anterior horn alpha motor neurons. A true, B false. Rentschau cells use glycine to inhibit discharging motor neurons and antagonize alpha motor neurons. So the answer to this question is true. Next question. All forms of Guillain-Barré syndrome are predominantly characterized by demyelination. A true, B false. This is a very abbreviated chart of neuropathies. We will go through it in the next few minutes, so you do not need to read it all at once. Acute polyneuropathy is regarded by many neurologists as synonymous with Guillain-Barré syndrome. Guillain-Barré syndrome is an acquired autoimmune condition. Our current understanding is that autoimmune system of affected patients become confused because of the similarities between some of the pathogen structural components and normal nerve structural components, and thus the autoimmune charges against normal nerves. This theory has only been proven in cases linked to Campylobacter jejuni infection, one of the many conditions that can trigger Guillain-Barré syndrome. Yet it is only in a minority of patients with Campylobacter jejuni infection that Guillain-Barré syndrome develops. Hence, concomitant genetic and or environmental factors must be at play. Some factors known to trigger Guillain-Barré syndrome are listed here. Stop the presentation and read them, or screenshot the frame and read it in your phone a little bit later. For now, we will continue. In order to make the diagnosis of Guillain-Barré syndrome, two findings must be present, at least according to some authors. The first one is progressive weakness in legs and arms. The second one is low or absent reflex in weak muscles. Yet, as you will see, as this talk progresses, some of the conditions included as variant of Guillain-Barré syndrome fail to meet this inclusion criteria. This figure was presented in Nature on 2019. Notice that among the variants of Guillain-Barré syndrome, a pure sensory variant is included. Yet, most neurologists I know adhere to the previously mentioned inclusion criteria, at least most of the time. Features almost always present in patients with Guillain-Barré syndrome are a trigger event or prodromal illness, to which we have already alluded, symmetrical weakness, elevated CSF protein with normal or minimal increase in cell count. This phenomenon is called albumin cytologic dissociation. And sensory findings. Sensory findings are not present in one subtype of Guillain-Barré syndrome called acute motor axonal neuropathy, very common in Japan, associated with Campylobacter jejuni. Features often complicating Guillain-Barré include respiratory failure, autonomic dysregulation like cardiac irregularities, hypertension or hypotension, and syndrome of inappropriate secretion of antidiuretic hormone that presents with hyponatremia. Hyponatremia due to this syndrome must be distinguished from immunoglobulin treatment-induced hyponatremia. Features usually not present in patients with Guillain-Barré syndrome that should cast doubt on the diagnosis of Guillain-Barré syndrome are more than 50 white cells per microliter in the CSF, severe sensory signs with no or little weakness at the onset of the condition, persistent or early bladder and bowel involvement, sharp spinal cord sensory level, and marked or persistent weakness asymmetry. Guillain-Barré syndrome is a monophasic, usually self-limiting disease. Treatment of Guillain-Barré syndrome consists of no steroids, vital function support, especially respiratory, and plasmapheresis or IV immunoglobulins. The most common subtypes of Guillain-Barré syndrome are acute inflammatory demyelinating polyneuropathy. If we look at this chart, which I showed you a while ago, patients with inflammatory demyelinating polyneuropathy have this presentation. In this presentation, sensory and motor findings coexist, but usually motor findings predominate. In this variant, myelin is the primary target of the disease. This diagram represents a normal motor neuron. This new figure shows a motor neuron under the attack of antibodies represented by the Y structures invading the myelin. This sagittal MRI shows enlargement and enhancement of the cauda equina. These abnormalities are consistent with involvement of thick myelinated fibers. In this frame, you can see a transverse non-contrast MRI of a patient with Guillain-Barré syndrome. Notice the cauda equina fiber enhancement once contrast is given. The findings in the MRI are the result of myelin disruption and lymphocytic infiltration of the nerve fibers. Electrical conduction through this fiber is very delayed and desynchronized due to the patchy nature of the pathology. The second variety of Guillain-Barré syndrome I will mention is acute motor axonal neuropathy. These patients present with muscle weakness and no sensory findings. In acute motor axonal neuropathy, the antibodies are directed against the axon, here indicated in red. Patients with acute motor axonal neuropathy have no sensory findings, as we previously mentioned. This condition is often associated with Campylobacter jejuni infection. This condition is very frequent in Japan, as we also previously mentioned, and antibodies are directed to axons proteins, hence recovery is slow and usually not complete. Nerve conduction studies reveal a drop in amplitude of the compound motor potentials that is out of proportion to the drop in conduction velocity, reflecting axonal damage. Sensory nerve conduction studies are normal. Next variety I will introduce is acute motor and sensory axonal neuropathy. The only clinical difference between this and the prior condition is that sensory nerves are also involved. And the last variety I will mention is Miller-Fisher syndrome. This variety corresponds to the type indicated in this frame. Notice the absence of weakness, except in the eye muscles, and the absence of somatosensory findings. So Miller-Fisher syndrome is characterized by ophthalmoplegia, ataxia, and areflexia. This condition is usually associated with antibodies against the ganglioside found in myelin and neuromuscular junction, especially in nerve ending for extraocular muscles. These antibodies are called anti-GQ1B. Now, going back to the neuropathy classification chart, and having concluded our brief discussion of Guillain-Barré syndrome, I'd like to mention some conditions that may produce similar finding. These conditions are acquired non-autoimmune neuropathies listed here: vasculitis, botulism, porphyria, and lead intoxication. Diabetes neuropathy is an special case because of its frequency and protein manifestations. Diabetic neuropathy usually produces an axonal small fiber distal sensory symmetrical peripheral neuropathy manifested by numbness, reduced ability to feel pain, and temperature changes, tingling, burning sensation, sharp pains, and cramps. Yet, in other cases, patients with diabetes may present with proximal weakness, as do patients with Guillain-Barré syndrome. Lyme neuropathy is common in certain regions of the United States and may clinically present in many different ways, at times resembling Guillain-Barré syndrome. Chronic inflammatory demyelinating polyneuropathy is easily distinguished from the acute inflammatory demyelination variant of Guillain-Barré because chronic inflammatory demyelinating polyneuropathy is not a self-limiting disorder. Sensory loss is prominent and progressive over months. A trigger is seldomly present. Chronic inflammatory demyelinating polyneuropathy is more frequent in older patients than Guillain-Barré syndrome, which is primarily a disease of the young. And also, unlike GBS, this condition, that is chronic inflammatory demyelinating polyneuropathy, responds to prednisone. Plasmapheresis and IV immunoglobulin are also effective in this condition. So the answer to this question is B. Next question. The culprit antigen in chronic inflammatory demyelinating polyneuropathy and Guillain-Barré syndrome is the same. A true, B false. In this frame, the yellow cylinder represents an axon and the blue myelin. I have now added a leukocyte to portray the cell responsible for the production of antibodies and divided the frame in two. On the left side, I will represent the pathophysiology of chronic inflammatory demyelinating polyneuropathy. For this purpose, I will introduce two proteins that glue the axon and the myelin together. They are called adhesive proteins. The green one is called NF155. The magenta one is called CNTN1. It is again these proteins that antibodies are generated in patients with CIDP. Now I'd like to call your attention to the other side of the line. In case of GBD, triggered by Campylobacter jejuni, component of this microbe have ganglioside-like particles, here represented by the wiggly aqua lines. Gangliosides are also present in myelin. Hence, when the autoimmune system produces antibody against the ganglioside-like particles in the microbe, they also attack the gangliosides in the myelin. The final event in case of CIDP and GBD is that myelin becomes unwrapped and demyelination takes place. But they get there by different mechanisms, as you can see in this frame. So the answer to this question is B. Next question. Myelin formation occurs as a consequence of Schwann cells or oligodendroglia membrane fusion. A true, B false. In this frame, we can see a cell, Schwann cell in the peripheral nervous system or oligodendroglia in the central nervous system engulfing an axon. I have now introduced a segment of the cell membrane. In blue, you can see the protein-rich component of the membrane. The white lines represent the lipid component. The light blue area represents cytoplasm. Thus, we have an outer membrane and an inner membrane surface. Here I have represented further encircling of the axon, forming the mesoaxon. I have now introduced the membrane following the same schematic principles as I did before. Here I have represented further axonal encircling by a clock-like advance of the myelin finger, as indicated by the arrow, producing an internal and an external mesoaxon, name used to indicate the external and internal opening of the tunnel created by the outer aspect of the membrane coming close to each other. The coming of the outer membrane surfaces together form a 6-layer structure, as shown here. The fusion of the external surfaces forms the intraperiod line, transforming the 6-layer structure to a 5-layer structure, forming the myelin lamella. The winding by clock-like advancement, as indicated by the arrow, continues as depicted here. This process is continued until the axon is surrounded by many layers of myelin lamella. In this frame, I have enlarged a segment of the infoldings. Here, I am indicating the inner surface of the membranes, with their surface in contact with the cytoplasm abutting each other. These surfaces also fuse, forming thicker lines called the major period lines. These lines are thicker because myelin basic protein is found between them. In addition, the cytoplasmatic island entrapped between the inner membranes at certain locations form the Schmidt-Laterne incisures. In this cross-section photograph, we can see the axon, the Schwann cell, the non-compacted myelin, the compacted myelin. If we take one small piece of the compacted membrane and expand it, we will see dark and lighter areas corresponding to the structures we have just mentioned. The darker lines corresponds to major period lines and intraperiod lines. The lighter colored bands corresponds to lipid tail of the cell membrane. This description is based on the reference shown below. So the answer to this question is A. Next question. Peripheral myelin protein 22 helps keep myelin together. A true, B false. Normal peripheral myelin protein 22, represented in this frame by the green rectangles, binds the darker and lighter lines together and so contributes to the stability of myelin. Myelin, as you know, decreases capacitance of the axon membrane and repels voltage-gated sodium channels from the surface axon covered by it, thus allowing a high concentration of voltage-gated sodium channels in the neuron via. Hence, myelin, by sustaining electrotonic conduction and contributing to the production of action potential at the neuron via, speed up conduction. On the other hand, no functional peripheral myelin protein 22 does not hold the membrane together. Unwrapped membrane breaks down in a process we refer to as demyelination. So the answer to this question is A, true. Next question. Patient with Charcot-Marie-Tooth disease. Most significant problem is not being able to stand from a squatting position. A true, B false. Now we are going back to the neuropathy chart to talk about hereditary sensory motor neuropathy, usually referred to as Charcot-Marie-Tooth disease. Charcot-Marie-Tooth disease produces distal weakness, often involving the distal regions of the leg and the feet, hence often present with foot drop, difficulty walking, and frequent tripping. Physical finding consists of inverted champagne bottle appearance of the legs, as you can see in this frame. In this frame, you can also see claw hand, denoting distal upper extremity involvement and varus foot deformities. This deformity in patients with Charcot-Marie-Tooth disease result from muscle imbalance with predominance of foot inverters, that is of the tibialis contraction over weaker foot everters, peroneals, also called fibularis muscle. Other foot deformities seen in these patients are pes cavus and hammer toe. These deformities occur because foot muscles are weaker than foreleg muscles, especially the tibialis anterior, peritonius longus, and toe extensors. Hence, their unopposed action elevates the arch and extends the toes. Later on, as foreleg muscles become weak, pes planus occur. Charcot-Marie-Tooth disease has many subtypes, usually based on inheritance and neurodiagnostic findings. Charcot-Marie-Tooth disease type 1 is most frequent. CMT type 1 is also known as demyelinating CMT. It is an autosomal dominant condition. Nerve conduction velocity is generalized and uniformly very slow, unlike in autoimmune neuropathies where slowing is patchy. The most common subtype of type 1, that is CMT1A, is caused by peripheral myelin protein 22 duplication, and a normal peripheral protein 22 fails to keep the myelin membrane together, thus myelin unwraps and demyelination ensues. This is a sural biopsy of a patient with CMT type 1A. Sural biopsy shows Schwann cell proliferation, and in an effort to myelinate the axon produces anion bulb formations. The axons are in various stages of demyelination. In this frame, I have introduced a normal nerve biopsy. Notice the regularity, size, and compactness of the myelin. Now notice the difference in patients with CMT type 1. This is a photograph of a single axon. The myelin around it forms layers resembling an onion. In addition to type 1, we have CMT type X. CMTX is an X-linked demyelinating condition, hence conduction is slow, and fathers cannot pass the genetic defect to their son, that is to the XY sons. CMT type 2 is due to axonal loss and may be associated with restless leg syndrome. The inheritance of this condition is usually autosomal dominant, but at times recessive. The amplitude of the compound nerve action potential are more affected than nerve conduction. There is also an intermittent form of CMT. It is called intermediate because the amplitude of the compound potential is as affected as nerve conduction, so it is hard to say if the condition is due to axonal loss or demyelination. So the answer to this question is B, false. Thank you very much for your attention.